to have a physiotherapist working over here, chiropractor working over there, surgeon working over there, neurologist working here, and a rheumatologist over there, and the patient has to decide where they're going to go, and sometimes they'll go on their own into various places, and sometimes they'll go serially bouncing from one to the other. I wrote an editorial in a special issue of a journal that I edited, where I said, currently, for a patient seeking care for spinal disorder, is like shopping in a supermarket, where you have aisles and products in every aisle. The labels are in a foreign language, and you're starving. And it is not appropriate for this. So the model suggests that we have to have a well-trained core or primary spine care clinician. This particular clinician must be able to do a detailed history and examination. They must be able to look for red flags or serious pathology, so-called grade 4 pathology, according to the Bone and Joint Decade Task Force. Determine whether there are spine-related neurological deficits, so-called grade 3. Determine whether the pain the patient's experiencing is disabling, grade 2. Or determine whether the pain is non-disabling but disturbing and requiring treatment, so-called grade 1. It's a simple model, but S's are not something that can be done without some focus of attention. It's virtually impossible for a family physician to spend the time and the energy to look at this. And it's no point sending to a surgeon, or they would be overwhelmed. 80% of the population gets back pain. We will never have enough surgeons to take care of the 90% of patients who have back pain, which is non-surgical. The second decision step that they have to make, a primary spine care clinician has to make, is if I have grade 4, if I have risk factors or red flags, I have to be able to do the basic diagnostic services, and or send a patient rapidly if necessary for specialist or surgical care, and to know the specialist and the surgeon, and to have a working relationship with that specialist or surgeon. If it's grade 3 with some neurologic deficit, I should be able to differentiate between those who have progressive or severe neurologic deficits and may require surgical intervention, and those who can be dealt with observation and non-surgical symptomatic care. If it's grade 2, I should be able to be skilled in offering the type of treatments that the evidence-based guidelines recommend, namely manipulative and manual therapy, exercise, education, and when necessary, some basic analgesics by a medical officer. I have to have those skills. And if it's grade 1, I mustn't start thinking I can treat everybody and get everybody cured. We don't do that. Back pain is a chronic, lifelong disease for most of us. It'll come, it'll go. It'll get bad, it'll get better. It'll have neurologic deficits. In some of us who are unfortunate, it'll become progressively worse and require more advanced care. But for the grade 1 person with grade 1 pain, which is just upsetting, most of the care is education and exercise to prevent chronicity and to avoid the risk factors. Maybe some limited symptomatic care. This is time consuming. A medical officer who's seeing 20 patients an hour cannot provide this level of care. A surgeon who is overwhelmed with patients cannot do it. We need some other individual or professional to do it. The third decision step is prevention. There has to be screening for serious pathology, deformities, and scoliosis. There has to be education of first responders, emergency room physicians, clinical nurses, and others. And there has to be education and communication with teachers, nurses, traditional practitioners, the general public, to inform them on risk factors so that the whole community is involved in risk factor and management and are aware of the treatment options and what patients might be benefit if they have spinal pain. So the primary spine care clinician must have the following skills. Must be able to do a history and examination, screen for red flags, and make a diagnosis. They have to do physical examination, neurological examination. They must be skilled in the manual and manipulative therapies. They must be skilled in being able to offer and promote and advance and encourage the appropriate exercises. And they must understand that healthy living, wellness, and education is the foremost and the front line of helping people with spinal problems. They're expected to be able to refer to tests based on evidence-based guidelines, understand the indications, benefits, and risks of spine surgery so they can talk to a patient about spine surgery. And when a surgeon has 5 minutes, they may be able to spend more time, reinforce the messages that the spine surgeon or the rheumatologist or the neurologist is trying to get across. They have to be able to identify systemic and inflammatory joint diseases and work with the rheumatologist and the internist to ensure these patients are not lost to follow-up, and be able to identify psychosocial issues where they exist and make appropriate referral and management decisions. So the model we're trying to evolve, and this is an evolving model. We're not sure we have it right. We want to see if we can test it. We want to see if it happens. But it's not only us. There's been articles in the British Medical Journal suggesting this type of model. There's a recent article in Spine, in the journal Spine, looking at the model, see if the model can come up in Canada. And there are other articles on this issue. So the core or primary spine care clinician does his detail. You walk in the door, I've got back pain, my spine hurts. They can be guaranteed to have a clinical history, a detailed clinical examination, that the non-surgical treatment is a non-advanced medical treatment will be available, and the patient will have to be educated. They have to be able to educate the primary contact clinicians. They have to be able to refer for testing and medical care. They have to coordinate the surgical care and ensure it follows appropriately, and they should be involved in the post-operative care. Now, there's some debate at who would be the best professional group to do so. The candidates at this stage are the doctor of chiropractic, a doctor of physical therapy, that's a physical therapist with advanced training in manual skills and diagnosis, or perhaps a doctor of osteopathy or a doctor of medicine who has elected to become a primary spine care clinician by studying spending their energies and focusing their attention on this one issue. It includes, the model includes community resources, the scoliosis and spine deformity screening, the simple screening for red flags for serious pathology. You can teach nurses and doctors that these patients should not be allowed to continue. They need to refer. Basic spinal first aid, educating on how to avoid chronicity, advise and educate, and do community education. And if we can train the traditional healers and work with them, if we can train the nurse practitioners, train the local community clinics in the emergency rooms, and teach the teachers and community leaders to become involved, maybe we can impact this epidemic of disabling spinal pain. The team also includes the tertiary management. This is advanced imaging, advanced laboratory testing, hospitalization when necessary, surgery of the nature we've described. This is extraordinarily skilled surgery. Hospitalization, advanced medical management of serious pathologies, inflammatory joint diseases, infections, fractures, and rehabilitation. The orthopedic surgeon and the neurosurgeon are the keys to this model working. The neurologist, physiatrist, rheumatologist, and psychiatrist play a definite role. Finally, there's the rehabilitation group, the fourth module in this, the management of the chronic disability, the education and support necessary, exercise therapy, behavior modification, work modification, home support, family counseling, and in this, the physiotherapists, the occupational therapists, the psychologists, and others play a crucial role in ensuring that these people who have chronic pain are able to manage, control their pain, and still function at a high level. So the model is a multidisciplinary, interdisciplinary approach, focusing around somebody who has the patient, who will see this patient throughout their life, be available to this patient throughout their life. This primary spine care clinician, the patient can feel they can go there and get the appropriate investigation and evaluation, can be referred from or to the community resources that are available for education and exercise, the nurse practitioners and the clinics, can be comfortable in ensuring that when they need or may need, because this person will not make a surgical decision, but may need and has some indications to consider a surgical consultation, rheumatologic consultation, a neurology or psychiatric consultation, and who works closely with the rehabilitation, the physiotherapists, the occupational therapists, and the psychologists. That's the model that's slowly evolving in this world in an attempt to control this epidemic. We're not sure it's going to work, but we, as I said, we're trying to investigate it. It's easiest to investigate in a treatment-naive community where the patients do not have huge options to go bouncing from doctor to doctor to doctor. And we are hoping we can get the type of funding necessary to do that. In conclusion, then, I want to express our appreciation again to all the speakers. They've done, I think, a fabulous job. We're very fortunate for everybody to be here. I want to express our appreciation to the sponsoring organization, and particularly to the Canadian Memorial Chiropractic College for funding the refreshments and the lunch. Our appreciation to the Cresta Hotel, once again, for the conference room, the Mahalapi District Hospital for their assistance in the World Spine Care Program to date, and to the Botswana Ministry of Health for their support. The future of spine care in Botswana is continuing with the current model. Establish a spine surgery mentorship program, which our spine surgeons have already started to investigate. Train through scholarships primary spine care clinicians who can take over the clinics. Open World Spine Clinics in other communities if we are able to do so. And then have regular spine care conferences such as this one with more specific training programs. We're hoping, for example, in the next, if we have able to develop another congress or another conference, is to have maybe a 2 or 2.5 day conference where one day would be general lectures like this, and then we'd separate out so that the physiotherapists and the nurses can have their own very hands-on detailed discussion. The surgeons can work one-on-one with the surgical speakers and really be able to get more up to date and have more time with it. Again, thank you very much for being here.